I think we can start now. So, dear colleagues, dear students, ladies and gentlemen, I'm Aisha Halidou. I am professor for the Alfred Chair at Sciences Po, and I warmly welcome you today to today's panel on COVID-19 challenge in France and Germany that I will have the pleasure to moderate. We will have contributions from some great speakers, essentially epidemiologists or epidemiology scientists. So all our speakers are epidemiologists. But before presenting them to you, I would like to say some few words about the Alfred Chair and the LIEPP, which I represent today. Both are the organizer institutions of the panel of today. The Alfred Chair is a guest professorship program that promotes an exchange between French and German scientists here at Sciences Po in Paris and at Sciences Po European campus in Nancy, where I taught health policy and global health this year. And as part of this exchange program of the chair, in terms of research, I am affiliated to the LIEPP, and the LIEPP is a laboratory for interdisciplinary evaluation of public policies. It is a research institute with different research focuses: economics, sociology, health science, many kind of sciences. So far, so good. Now let's come to our speakers. The first one I'm going to present is the one who was my epidemiology professor close to 15 years ago, when I was student at the Public Health Department of Hamburg University of Applied Sciences in Germany. That is Professor Alfred. So welcome to you, Professor Alfred. He is still an epidemiology professor there in Hamburg. He is also professor for infectious disease epidemiology at Tampere University in Finland, and also consultant for the World Health Organization and also for the European Union. He is a member of the COVID-19 task force for the Association of Schools of Public Health in the European region, ASPA. Okay, so ASPA. So welcome, Professor Ranches.
Thank you very much.
The second speaker is Professor Arnaud Fontane. He is professor at the Institut Pasteur and the Conservatoire National des Arts et Métiers. He is member of the Scientific Council on the COVID-19 crisis, so-called Conseil scientifique sur la crise COVID-19. He advised the French government. So last week, one of my colleagues said to me, "You have a star on your list of panelists." So welcome to Professor Arnaud Fontane. Our third speaker is Professor Wolfgang Hofmann. Wolfgang Hofmann is professor for population-based epidemiology on healthcare and community health, managing director also for the Institute for Community Medicine at the University Medicine Greifswald in Germany. He is co-founder of the German Association of Epidemiology, DGEPI, and I first met him also by the first Congress of DGEPI in Greifswald. It was 2005. I think I was one of the rare students who was at this Congress among a lot of epidemiologists researchers at that time. So welcome to Professor Wolfgang Hoffmann. I'm glad to have you here among our panelists. And he is also a member of the Commission of Monitoring and Health Reporting at the Robert Koch Institute in Berlin. Last but not least, we will have Professor Antoine Flahaut. I hope I speak your name very good. He is a professor of public health at the University of Geneva, Switzerland. He is also director of the Institute of Global Health, deputy director of the Swiss School of Public Health in Zurich. Welcome to Professor Antoine Flahaut. Once again, the panel will discuss about how COVID-19 pandemic has been handled in France and in Germany, the challenge we faces or we are still facing now, also about things that went wrong and how we can do better. And for that, we have all these speakers, so epidemiologists from France and from Germany. Antoine Flahaut, he is actually in Switzerland, but he is also a French scientist, French epidemiologist. We will have a discussion at the end of all presentation, and I want to suggest all participants who will have questions to send them through the chat. I'm going to collect them, and at the end of all contributions, our speakers will try to answer all those questions. So welcome to you all speakers and welcome to you all participants. And I think we can start with Professor Ranches. Professor Ranches is going to make a general analysis about the COVID-19 in France, in Germany, and in general, I think. So welcome to you, and you can start, Professor Ranches.
Bonjour and good morning from Hamburg. Thank you very much. It's a great honor for me to be a part of this meeting today. And I'll just start this presentation. Okay, I hope this is visible for you now. Okay, thank you very much. Thanks very much for the organizers and ISA. Lots of thanks to you. Okay, epidemiological challenges of COVID-19 in France and Germany. I'll just try to give an introduction into this. If we first have a look at the commonly available data, like the reported cases here for Germany and France, Germany in blue and France in red, you can see that the epidemiology, the trends are rather similar. Both countries experienced 3 waves so far. Probably we will see a 4th wave in the autumn, and okay, the magnitude of the reported cases seems to be a bit higher in France, and actually also the waves usually started a bit earlier, and but if we have a look at reported fatal cases, we see a more striking difference. We see that that the number of reported fatal cases in France in the 1st wave were dramatically higher than in Germany. So something probably went quite well here. This rather good situation could have was still available until the autumn, beginning of the autumn. Then the 2nd wave started in France first, then before the 2nd wave in Germany. But here things didn't go so well, obviously, in Germany, with relatively high numbers of fatal cases. And the future will be interesting to follow. Unfortunately, these are very sad numbers, I must say. So ISA provided us with 4 questions, and let me raise them one by one. So the first one was, what went wrong? Before talking about what went wrong, as you could see, some things went quite well. So many things went well, I would say, at least during the first wave and the first summer, in some way, at least looking at the numbers of reported cases. First of all, contact tracing during the first went pretty well in Germany, because, at least better than in other countries. If you compare, for example, with the United Kingdom, existing structures were used and contact tracing was relatively effective. Also, physical distancing, as here graphically shown, was followed by, the advice was followed by parts of society. And therefore, the first wave really could be reduced relatively quickly. And during the last summer in Germany, the situation was pretty well because the epidemic was not generalized so much. It was more driven by local outbreaks, as here is represented by one outbreak in a meat factory in Germany, was the biggest one described at that time. And you could see that due to the implementation of quarantine and quick outbreak management, for a while, the epidemiology was controlled relatively well until it then generalized more in the autumn. A few words more about contact tracing. Of course, it's difficult in a setting like this from the last summer, or probably you could see it also these days again in Germany, where people feel like, oh, the situation, the epidemic is over. Once again, like last summer, we know what happened. It was not over, and contact tracing is a very important factor, as here represented in this graph from one region, Hamburg, where you could see that, for example, this big school outbreak, the network was discovered relatively well, several other smaller ones as well, but the majority of cases are usually only seen here as pairs or triplets, which indicates that the something about this pathogen and the spread of the pathogen, it's not so straightforward, and often we miss a lot of the cases, which is represented here also in this slide, which really tells us, for us epidemiologists, it's very interesting and very exciting to learn day by day. But the problem is we only see the tip of the iceberg. We see the fatal cases, we see the clinical cases who need medical care or hospitalization, but the milder infections or asymptomatic infections, which are the bulk of the cases, are often invisible, and which make it really difficult for us. So many things went well, but what went wrong? At first, no plan. I think working in this field for more than 20 years, I know that about 20 years ago, 15 years ago, Germany was much better prepared for a pandemic. We had very up-to-date pandemic plans for flu pandemics at that time. We had exercises going on at local and national level. This actually was a bit forgotten over the last 5 to 10 years. It was a bit, people were too reluctant, maybe because the SARS-1 pandemic was controlled relatively quickly, and because maybe of the experience with the swine flu, that things are not going to be so bad. Actually, that was wrong. Secondly, really big factor, which is currently still ongoing, at least in my experience here in this country. I really am looking forward to hearing the experience from France, but here risk communication was and still is a big problem, I think. An example for this was at the beginning, the situation talking about masks. Even officials were doubting the use of masks, whether it was useful to use masks. until then finally months later it was decided that wearing of masks was compulsory. And now the discussion again goes in the other direction, like in several states in Germany now, masks are not mandatory anymore for school children, even though all of them are unvaccinated, almost all of them, and schools are full. So we will contribute to the fourth wave. The risk communication problem actually probably is based on missing epidemiology. What I think for the four of us, it's I've got a real question like, why aren't there more clear-cut epidemiological studies really identifying what are the real risk factors and what are the big ones and what are the smaller ones, which could guide policy making? I think they are a bit missing, but they're also not requested by policymakers at the moment. This together with data collection problems and the vaccination procurement problem, which is a common European problem, that it took quite a while until we got and until we will get enough vaccines in the near future. Just an example, for a brief example, like about the epidemiology. For example, there was one publication here in Nature which rated a bit the effectiveness of different interventions at some stage. And policymakers tended to use, at least that was my experience last year, to use the ones here in the lower end, which are less effective, and try to avoid at first the more effective ones at top. But here, epidemiology can contribute a bit more. And risk communication should be made very easy, like in this example from Iceland, because people really forget about, like, what does it mean, 2 meters distance? In Iceland, a country with lots of sheep, that's a very nice way of showing how far people should stay apart. Okay, what are the current challenges? Here, as the director of the World Health Organization has mentioned 100 times, is no one is safe before everyone is safe. So we need to vaccinate everyone, not only in the richer countries like ours, but also worldwide. We have to think about new variants. We are hearing more and more about the Delta variant in India, in the UK, now in Portugal, and just wait a few more weeks until you will see it in France and Germany as the dominant variant. And why is this going to be? Because of what is going to force this? It's going to be import. Think about beautiful weather, holiday period is coming, and everybody seems to have no other plans than traveling as much as possible now. And here again, risk communication is a challenge. We need to get things clearer across. How can we do better? Last but not least, what about a European approach in infectious disease control? I know I've been working a lot with international colleagues over recent months, but actually, and we do have a European Center for Disease Prevention and Control, the ECDC in Stockholm. But actually, if you ask yourself, how much was this a common approach, because it's a common problem? I feel there's a long way which we can go, and we should, at least in pandemic control or in epidemic control, we need to work together much, much more. And we need to work in a common way, because it's only a question when the Delta variant from the UK will reach and will dominate in the rest of Europe, just as one example. What about better planning and preparing for epidemics and pandemics? I think there's we used to be better. We should become better again, and we should really prepare and not forget, like, if 5 years or 10 years there's no pandemic, forget about it. The one question which we usually say in this area is, one thing is for sure, the next pandemic will come. We just don't know when, but times can be relatively quickly, as you experienced since a year and a half. And last but not least, I really want to say, as one of the things we really should think about is, like, why do we accept the healthcare capacity as a limit and indicator needed for action. So I often hear this discussion, oh, there are still some intensive care beds available, so let's get, don't worry, let more people get ill and die. I think this is not an ethical approach. We should really try to control this pandemic and future pandemics in a way not only about capacities, we should think about people getting ill and people dying. So where do we go from here? I don't know if it's going, I wish we were going here, but I suspect we're going there. And therefore, I'm very curious about the comments of my colleagues from France and of Wolfgang's comments. Thank you very much for your attention.
Thank you to you. Thank you very much for your contribution. I think we can go directly to the next speaker. That will be Arnaud Fontanet. Professor Alfred already pointed the way or how we are going to how to call it to manage how it will be managed by the policymakers. Can you, as advisor of the French government, try to explain to us how you experience it during your work at this Council of Conseil Scientifique, and also to try to make the comparison on the kind of management way of the crisis in Germany and also in France. Welcome to Professor Arnaud Fontanet.
Thank you very much, Aissa, and thank you very much for organizing this event. I'm really pleased also because I'm really eager to learn from the colleagues and the very nice panel that you have put together on issues which we have not completely solved or understood yet. Can you see my screen here?
Yes.
Yeah, okay. So I will start with this comparison between France and Germany, and stealing a slide that was just shown before on the comparison of death per million people between the two countries. At the very beginning of the epidemic, France has been hit very severely as Italy and Spain. And we were all very amazed about how well Germany had done. And these are two countries of about similar size, similar structure in many different ways. And therefore, I think the comparison was reasonably valid. What I was wondering, though, is how much chance played a role at the very beginning to explain why France was so badly hit and not Germany, or whether it had to do with the way we were prepared. Just to recall what happened in France, we had reasonably well handled situation in January and February. Basically, there had been 6 introductions of the virus in end of January in France. Again, a cluster in the Alps in early February. But each time, patients were identified very quickly, put in isolation. All the contacts were tested. There was no positive contacts. And we were just wondering at that time, like the rest of Europe, what will happen next? I mean, is it that after all, if we isolate very early, we can handle this epidemic? Or is there something worse that will follow, like, because we could see how China had been very badly hurt. And if you look at what was happening in Asia in February, there were small outbreaks all around Asia, but they were all controlled, except for this diamond process ship in Japan, you know, which was a very special situation. And I have to say that until 25 of February, basically, or 20 of February, I was unable to say what would happen next. And then everything went wrong in the last 10 days of February. We had Italy getting into flames with these first cases diagnosed in 20th of February, and then very quickly situation deteriorating. we learned that Iran was also knowing a very difficult situation with some cases exported to Lebanon and Canada. In Korea, there was a first very large cluster in an evangelical church in Daegu at the end of February. And in France, we diagnosed the first cases from part north of Paris on 25th of February. And the investigation which followed showed that the epidemic had gone there for quite some time. We had cases coming back from Egypt, from cruise ships of Egypt. And we had this evangelical church in Mulhouse event where probably close to 1,000 of people got infected at once in 5 days, 17 to 22 February. And then we completely turned upside down. And there was a huge acceleration of the epidemic, Italy, Spain, and France, and then lockdowns, everything. And countries like Germany and Northern Europe, in a certain way, could put in place those measures much earlier because they could witness what was happening in countries like Italy, Spain, and France. So I was just wondering, well, maybe what happened to us was bad luck. We had this huge evangelical church cluster, and until that time, we were doing pretty well. And that may explain the difference. If you look in a bit more details, in Germany, you had a large cluster in Bavaria in the first 2 weeks and you did manage to control it. So you had a tracing and testing system which was quite operational, and you were testing much more than we could do in France. Not to the level we are testing today, far from that. But you were among the different countries in Europe, the one that was testing best at that time. In France, unfortunately, if you go back to the cluster north of Paris in the Oise, you realize now that there had been 5 hospitalizations in small hospitals nearby, Compiègne, and the physicians didn't think of COVID because the patients were not coming from China, and we had this idea that they were coming from China, did not send the samples to referral hospitals for testing, and we missed this cluster of Oise, which became very big. And what I realized today is that if by early February, we had been in a position to say any person hospitalized in France with a pneumonia that is not flu should be tested for SARS-CoV-2, maybe we would have picked up those cases in the Oise. And realizing that we had an outbreak going on there, which had started in end of January, started to take measures more global. And for instance, forbidding gatherings of more than 1,000 people, like the one that happened in the Evangelical Church of Mulhouse, and we would have a recent history. But of course, this is very easy to say today. So there was a little bit of bad luck, and there was a little bit of, unfortunately, we were not in capacity to test at least all hospitalized cases that had a pneumonia that was not flu, and that's maybe where we missed it, because we were certainly far from being able to test all people who had respiratory symptoms in the middle of a flu epidemic. At the time, we didn't have the capacity for testing. So this is retrospectively the analysis I'm doing, and but I would be curious to have your comments on that. If you look now at what happened next, you see that the two countries work reasonably well in parallel, except that for the second wave, which took place in the fall, you were a little bit more strict at the beginning and managed to delay a little bit the rise in number of cases and deaths. I prefer to use the deaths because there were very different testing capacities between France and Germany. At the beginning, you were testing much more, but towards the second half of the epidemic, we were testing much more. So death is probably an easier way to compare the two countries. But then you ended up with not being able to control the second wave. And I'm curious to get your feedback on that. At some point, we were feeling like maybe Germany functions better because you are a federal state and you know how to decentralize and the operations, whereas for France, it has been very difficult. We are a very central state, and it took a lot of time before at the periphery we could function autonomously. But from what I understood, this federalism did play a little bit against you, because then the lenders started to want to do whatever they wanted with the COVID fatigue, and it became much more difficult for Angela Merkel to get people do what she wants them to do. And maybe that explains why you had this delay. But finally, you made it in January, and we can see that your curve is going down. Whereas in France, we stayed in this very high plateau. And indeed, we had a little bit of struggling with the government. Everybody is aware of it. At the end of January, when we asked for a lockdown, which the government was not willing to follow just because they felt like it's the population is not ready to have another lockdown. And if there is a chance to avoid it, or maybe just to delay it so that it would happen at the time that the vaccination campaign would be sufficiently advanced, and maybe the climate also would help, then things would go naturally back to normal, which is somewhat what is happening now. We sort of accepted this large plateau and the elevated number of deaths. There is a very interesting paper in Le Monde today for the French readers that is calculating how many human lives, intensive care units or whatever, this policy has cost us. At the same time, I think the society accepted it in France. People started to complain about those hospital doctors who were called being alarmist, you know, telling people that we are going to a next catastrophe or whatever. And scientists ourselves, we also became very unpopular, and people were accepting after all. They were saying, if the hospitals can handle it, let them handle it. We don't want to learn of it. And we want to keep a little bit of our freedom. I myself feel that it was not a good calculation, because at the end of the day, it ended up with a lockdown again. And so probably why not do it earlier? But I have to say that the society probably believes that this handling of the situation in the first trimester from the government was probably the right thing to do. And so this has to do with how society got exhausted with this very long series of lockdowns or whatever. And I will finish with just one word. I may not be as pessimistic as you are. Is it France, your first name? Sorry. The one.
Ralph.
Hmm?
Ralph,
sorry.
Yeah.
I'm not maybe as pessimistic as Ralph regarding the fourth wave. I truly believe that indeed the Indian variant, so-called Indian variant, will become dominant in France very quickly. As it did in the UK. There will be a rise in number of cases, for sure. What is really important is to know whether vaccines work against hospitalization. And one plausible scenario would be that we have a rise in number of cases, but not that much in the number of hospitalizations, provided the people continue to immunize. We are about at the same pace as Germany for immunization, except that you're a little bit ahead of us, but not so much. And in that case, that would be fine. But there is still a hole in the around the schools, as you were mentioning, Ralph, very rightly, which I think we need to immunize adolescents, because in the fall, this is where the virus is going to circulate. And if we are in tension, we will have to close the schools again. And we should not close the schools again. I mean, they need to go back to school. That's absolutely sure. So I still have a hope that we may have an epidemic, but not that severe, because vaccination will protect against the severe forms with the Indian variant. But I have to say that this is very, I wouldn't say speculative, but I don't have hard data to support it. And I'm watching very closely what is happening currently in the UK, because this is telling us what will happen in France in September, I guess. Thank you very much.
Thank you very much to you for this contribution. And I think we will go directly to the next speaker, that will be Professor Wolfgang Hofmann.
I have to give you back your screen. I'm just struggling with that.
Okay.
Yeah, here it is.
You have it?
Yeah, it's moving between the different screens, but I got it.
Okay.
So it should be okay now.
Yeah. Okay, I am saying that the next speaker will be Professor Wolfgang Hofmann from the University of Greifswald in Germany. And he will tell you, already pointed the situation about the education, but there are many lot of area who have been influenced, and also people who are suffering about this pandemic. And we have the case of the people living with dementia. And Professor Wolfgang Hofmann in Greifswald, they did a study about this, if he can present it to us today. Welcome to Professor Dr. Antoine.
Thank you very much. So I'm struggling a little bit with my screen. So, but now this should be visible. Is it visible to you?
Yes.
Okay, so I have to confess that I'm the only non-COVID researcher in this panel. But maybe that's why Aissa asked me to present some, let's say, other aspect that is maybe also important for the next pandemic to manage better than we did this time. And there were some surprises to researchers in healthcare. One I will present today. I will show data from the DZNE and also from the NACO health study. And this is an example, of course, and is a, let's say, anecdotal chance that we had to look into what is happening on the other side, on the people's side. The DZNE, to start with, is a national center for research on neurodegenerative disease with now 10 sites, and we are one of the sites in the uppermost northeast. So in case anybody doesn't know where Greifswald is, it's up there. It's close to the Polish border. I didn't know when I applied to there where it was. So let me see.
It is a nice place.
It is definitely a nice place, and it's not as hot as in the rest of Germany right now. So we are doing dementia healthcare research with the most enthusiasm on interventional studies. And one example is the study on intersectional care management. So this is a problem in care for people with dementia or cognitive impairment. When they enter the hospital and when they are discharged, there's usually a break in the line of care, and people get lost along this line, and then everything gets out of control, which was better organized before that. So we try to have a management of the discharge process in this study. So the primary outcome that we were looking at, so we have a scheme that is not in the focus of the talk today, of course, that is geared towards managing this transition processes of people with dementia into the hospital and out of the hospital again. And the primary outcome of this intervention study was the functionality of daily living. Back at home then, readmission rate, institutionalization rate, and of course quality of life and utilization of services, of care services, which then became interesting for what I will be talking about in a minute. But that was only the plan, because after recruitment of the people in the hospitals, then came SARS-CoV-2 and all the regulations associated to that. So we introduced social distancing, which was on the day when we completed the recruitment put in place. And so there was no other hospital intervention. Again, we could not work on the lately recruited patients anymore. We could not visit them at home, which of course was another bad thing, because the part of the intervention was obviously at the homes of the patients. And so the intervention dose was reduced, threatening the whole effect of the study, of course. We had delays and challenges to develop a hygiene regimen, because most of my staff is working in the field, so they were not allowed to see patients anymore, who are mostly belonging to the risk group for SARS-CoV-2. And the repeated lockdowns locked us also in as much as our patients, so there was delays, limited data collection, and so on. In order to deal with that, we turned into phone calls, which is not usual in people with dementia, but it turned out quite effective. So we gave them a lot of phone calls, and they actually liked that. So we were in contact with our participants, and we used the opportunity to ask for other things that were not part of the originally planned study. So the other thing that needs to be taken into consideration is that for healthcare research it was not a good time, because everybody was talking about SARS and nobody was interested in any other diseases. And we now start finding out that many other patients have been treated not as well as we would hoped it to be, and so we will have other fatalities due to SARS-CoV-2 and other diseases not associated to infections. So we used in this case the opportunity to ask our participants with cognitive impairment for other things. We had 141 that we could include who were able to answer regular phone interviews, and we asked them about impact on medical care of the lockdown, the impact on social activities, the psychosocial burden, and the care and support situation at homes. So this is the first result. This is the social activities. So you can see everything that is red has been less frequently after beginning of the lockdown. Everything in green has been more. So as we would expect, there was more phone calls, more talk with friends on the phone, more use of computers among these patients, knitting, other crafts and so on, whereas there was much less activities in visit the barber, which was prohibited, that only illegal barber activity was present. In home visits, for example, meeting friends, visit birthdays and festivities and so on, and go dancing was basically not possible anymore. The care provision was also affected quite significantly. So, for example, day clinics and services for people over the days were, for example, to release the caregivers, the informal caregivers, the relatives of the people with dementia, were no longer available. They were closed. Relief services of other kinds were grossly reduced. There was no podology, there was no physiotherapy, and mobility, of course, was worse than before. And that was our patients also reported. Actually, the majority still said that there was unchanged for them. For me, mostly meaning that there was not enough treatment to begin with. So, and if there's not much happening, then of course it can't be reduced very much by the lockdown. So it has two sides, this not too bad picture here. So, and then we asked the people, applied psychological test instruments, and I will summarize them in the next part, but also ask them for their subjective perception. So, for example, do you feel sufficiently informed? And actually, most do. Do you know anyone infected? Almost nobody did. Do you think the measures are appropriate? Most agreed. So this is a very compliant section of the population. Do you feel worried? Actually, almost nobody felt very much worried. So moderate, yes, but not strongly. How stressed do you feel because of corona? Very few felt strongly stressed. And they are not so much concerned about their own health. They're actually more concerned about the health of their family and friends, which was interesting to see for us. So, contrary to the expectation, this is not a highly stressed population in this situation. Has your everyday life changed? Actually, not so much. As we have seen on the graphs, moderately, but the majority says not at all. Visiting restrictions for nursing homes have not affected them very well, so at least in this sample. So the study shows a small impact on psychological variables, but this also, I didn't show you the data, but variables like depression, anxiety, and loneliness was not grossly affected. There is, of course, a major decrease in social activities, and the impact on healthcare provision is prominent. Maybe because of a lack of healthcare provision before, there was not so much of a change as we would have expected. Of course, we need more studies, particularly representative studies, which are not available in this population right now. Yeah, and at the same time, we had the chance to ask the general population as well. And the chance was in the NACO Gesundheitsstudie. Maybe you have heard of that. This is the largest German cohort study consisting of about 205,000 participants right now. At that time we had some 160,000, and they were quickly set up an interview study with questionnaires mailed and also with phone interviews in these areas of Germany where the sites, the recruitment sites of the national cohort happen to be. One of the centers is run by our institute in Neubrandenburg. So there was 113 or almost 114,000 people receiving the questionnaires and sending them back. Actually, this is the return. So we had this number of questionnaires to analyze. And what they reported is that we did have large numbers with upper respiratory tract syndromes and also with SARS-CoV-2 tests, which were about 5,000 here. And some of them had symptoms, some of them didn't have. So this is the, let's say, population representative or almost population representative figures that you can see here. There were also people who were tested positive for SARS-CoV-2, so altogether 340 in this large sample, and we could compare their experiences and their symptoms with those who were not tested positive. And you can see here the difference. So of course the symptoms in terms of upper and lower respiratory tract are different between the two groups. The number of people bedridden, sick leaves, also tiredness, headaches, cough, and so on, the typical symptoms associated with SARS-CoV-2 infections. What we see here is the prevalence in people with no SARS. This is something that we will really desperately need in the near future when we talk about long COVID, which of course is very hard to differentiate from a major prevalence of these symptoms that we had before. Hospital admissions were highly, of course, increased among those people who tested positive. Of the psychological measures that we applied in this population sample, measuring stress, depressive symptoms, and anxiety, the number of people getting worse was higher. So this is the difference between before the pandemic and in the pandemic. And there were many unchanged, but there were a higher number of people getting worse. And it was an apparent contradiction to what we found in the smaller study, but the surprise was, and this has been observed in other studies as well, was the age distribution. So the ages that we assumed would be the ages that suffered most were not the ones that suffered most. So the older people actually coped well or better with the changed situation, whereas the younger and middle-aged people were stressed a lot more. So they hadn't been in the focus up to then very much, and there were several studies coming out confirming that, also from other countries, that we should focus more on the people in the working age and even younger, who were apparently much more in need compared to the old people. So my personal consequence of this for the moment is that we really do need science, and we need to have more science and better science and quicker science when it comes to unexpected events like the pandemic. And also to manage the crisis, we have all seen that research was the key. So that is I know I'm preaching to the converted already, but that's something I also talk to the people providing care in Germany who are not so political in their views, but they need to understand that healthcare and research need to work very intensely together in terms of a crisis, and I hope next time we will. This time was a little hard for the researchers. Yeah, there were many people involved in this kind of studies, and I want to thank them, particularly René Thürian, who did the work on the phone study with our dementia patients. Thank you.
Thank you very much, Professor Hoffman, for this contribution. And I think it was very, very important for our participants to go through all this influence of the crisis the pandemic crisis on other disease. And your study is a very enlightening part of these cases. So we go directly to our last speaker, that is Professor Antoine Flahaut. And he will talk about the COVID-19, the COVID-0 strategy. Right?
Thank you.
Yeah, welcome to you. Yeah.
Thank you very much for having invited me to this this panel, which is highly fascinating. Guten Tag, mein liebe Kollegen. Bonjour à tous. So yes, I will try to talk about this zero COVID strategy. First of all, just to show you very quickly what we are producing every day. It's a 7-day forecasting for each country in the world and 209 countries where we have available data with some gray zones, unfortunately. But the situation is, of course, getting much better in most part of Europe and North America today. But it was for a long time very calm also in many parts of the Pacific and Asian countries. We produce some various more detailed data on this dashboard. What I want to show is 20 years ago, there was a meeting in the CDC Atlanta where a seminar, I would say, where they defined the 3 key strategic choices for pandemic response. And the 3 choices are either mitigation, which is really what we do for influenza because we cannot eradicate, and we never eradicated influenza viruses from the planet. Mm-hmm. So we just act, the interventions occur to avoid overwhelming of the healthcare system. And we know that at every peak of seasonal outbreak of influenza, we try to avoid the overwhelming of the healthcare system. The suppression strategy is the one which really has been used successfully to fight against the AIDS pandemic. We cannot eradicate it. We do not have a vaccine available for that. But what we can do is to treat as many patients as possible and as early as possible to minimize the health effect to them. And the third strategy is the strategy of elimination. We will speak about eradication when it is elimination at the planet level, and that occurred for smallpox. It is currently occurring for polioviruses. It was planned to occur for measles and rubella, but due to vaccine hesitancy, it never happened to be achieved for the moment. Mm. So most of the countries were prepared, and it has been said and reminded by Raf at the first talk that most of the countries were prepared against an influenza pandemic, even if the level of preparation in the Western countries were lower than in the Asian and Pacific countries. But COVID-19 is not influenza. First of all, over-dispersion, which is the distribution of the R0. You know, the R0, the reproductive rate, the basic reproductive rate is a variable. It has a dispersion, it has a distribution, and the distribution is very, very special for the coronaviruses, either for SARS or for COVID-19. And it is, the over-dispersion means that 90% of the contaminated people will never contaminated more than 1 or mostly 0 people. So only super spreader events do spread the disease, as Arnaud mentioned it for France in early March or late of April. You see the distribution of R0 is very, very different. There is no over-dispersion at all for influenza. The second point is the incubation period is not the same between the two diseases. For influenza, it's very short. 1-2 days, usually, you do not have time to trace people, to isolate them effectively. When you have, you buy this time a bit more for SARS, if you are agile enough to search for them, to test them quickly and to search for them, you have an average of 5 days and sometimes up to 2 or more days of incubation. Severity is not the same. You have not one COVID-19 disease, you have 3 at least disease. Below 50, we could say, yes, it's more milder than influenza. You have almost no mortality. I'm not talking about COVID, long COVID, you're right. We should also address it. But in terms of mortality and complications leading to hospitalizations, below 50, there is not such much risk. It was for the original strain, and that's a series from Denmark in the first wave. So the mortality figures are probably lower now and a bit different according to age. But even so with comorbidities between 50 and 70s, and half of the patients in this series had comorbidities at this age segment. They experience a disease which may lead to something like 10% of mortality, which is very close to the SARS, the former SARS, which was due to a coronavirus 2, the coronavirus number 1. And above 70, with or without comorbidities above 80, you are in a situation which is very close to the Ebola virus in Western Africa, with sometimes up to 20 or 50% of mortality among positive people. And that sentence, COVID-19 is not influenza, has been pronounced by Jacinda Ardern, the Prime Minister of New Zealand. When they experienced the first wave, they behaved as we behaved, as if it was an influenza pandemic. And they realized it was nonsense. It was not influenza. And they decided to move to an elimination strategy. You know, most of the countries in the world, Russia, Central, Eastern Europe, Middle East, Canada, USA, Switzerland, all the EU countries except maybe Finland and Denmark, all adopted a mitigation strategy which is associated to a mortality which is above 80. It's rather more than 100 deaths per 100K population in Germany and 150 in France. What is the mitigation strategy is to act to avoid overwhelming the healthcare systems, ICUs. So the lockdown measures and all these measures, even closing schools at last resort, are taken very late in the process of the wave, usually at the top of the wave or close to the top of the wave. And you can see in Czechia, which is very representative of all European countries, you have waves and lockdown and easing lockdown and wave again and easing. And so Ralph mentioned the fourth wave, which is obvious to come with such strategy. The suppression strategy I mentioned is an Asian response because it is applied in Japan and South Korea and Pakistan with very successfully, but it is also applied in Finland and Norway in Europe. The mortality is below 20 deaths per 100K, so it's much more effective in terms of health performance. In fact, they do not allow high waves. If you see the waves in South Korea or in Japan, for instance, in Japan, 126 million people, they never experience waves higher than 6,000 cases per day. So this is almost the low tide in Germany or in France, where the Japan know the high waves for them. They applied strict border control, backward tracing, extensive use of digital traces, effective quarantines and isolations, and they act as soon as incidences increases. Elimination, the zero COVID strategy, is that one which is chosen by China, Taiwan, Vietnam. I put them in bracket because they experienced a wave very recently, but under control now with a few cases, in fact. New Zealand, Australia, New Caledonia in France, and Iceland in Europe. Mortality is below, and sometimes much below 1 death per 100K. So it's 100 times less than Germany. They have a zero tolerance to virus circulations, strict border control, and I would say, in fact, border closure. Backward tracing, use of digital traces, same as for the suppression strategy, but acting at the first case. They do not allow any case to circulate in the country. And that was very successful in China, in New Zealand, in Australia. Just a few points. I mentioned backward tracing. In fact, there are two approaches for tracing. The forward tracing is the mitigation style strategy for tracing. You research the contact of the reported cases. When Japanese or Korean applied backward tracing, which is in fact the research of the chains of transmissions. You research the contacts of the parent case, of the case who had contaminated you. Because if you find the one who has contaminated you, he has at least contaminated more than one person, you and probably with high probability another one. So it's much more efficient as a method when there are these over dispersion. The forward tracing is, yes, maybe applicable for influenza, but backward tracing is much more adapted for over dispersed data. So you can see here the three curves. I go fast. Yes, not only health indicators, also economic indicators are much better in the countries which applied either suppression or elimination strategy. Here, the BRICS are, yes, really meaningful in terms of the health, the growth of the gross national product, which is positive only in China. It is also in Vietnam or in Taiwan. In Japan, it is much less impacted than in European Union countries. In Switzerland, it's a kind paradoxical because we applied, of course, a mitigation strategy very close to that one of Germany, for German part of Switzerland, very close to that one of France or Italy for the Latin part of Switzerland. But the economic indicators is much better in Switzerland than in other European countries, but for probably other reasons. So my conclusion is, first, we cannot predict. I don't know if there will be a fourth wave or not from my side. And I think we refrain to predict beyond 7 days. I don't think any models today are reliable enough to predict beyond 7 days, to tell you. Maybe we have, of course, a big hope on vaccine. And as Arnaud mentioned, vaccines may make the difference between the last summer and this summertime. But maybe we have too much hope in vaccine when we see what is happening currently in the UK, for instance, not talking about Chile or other countries. Mitigation has clearly failed. In all sectors, health, social, many more lockdowns, school closures, and mask wearing, and so on. Economics, as I mentioned, suppression was a strategy which performed much better. Elimination was the best one. So suppression is very pragmatic, and it may be a first step before moving to elimination, but at least suppression performed much better. I don't know if eradication from the planet is possible. I think WHO said much too quicker that it was not possible. But I think the good thing is that they initiated a discussion. We need first to discuss, is eradication possible? There is no animal reservoir. It's not true to say that there are animal reservoirs of the current SARS-CoV-2. Today, there are no animal reservoirs. Maybe there are some. They have not been discovered yet. There are other aspects of eradication which should be discussed. If we consider that eradication is possible, we need to prepare it, not just vaccinate the rich people, but also the poor one. And Africa is in a very, very worrying situation. And we do not imagine that if Africa turns as India in the next weeks or months, it will be a nightmare. devastation. That should be coordinated by WHO, and that needs to be funded by rich countries, high-income countries. So, of course, when I'm talking about no COVID strategy, many people say yes, but it's on island only. Here it is Samoa, and Samoa is a no COVID country. Fortunately, it's a very small island in the middle of the Pacific, much easier to control borders in these situations. I agree with that, like Iceland. And my last slide is not very elegant. It's just an advertisement of a book I have published for that in French only. My thanks to your attention.
Thank you very much, Professor Flau, for this contribution. And we are going to have the discussion for some few minutes. I don't know if Fontanet is still there.
I'm here.
Yeah, okay, that is nice, because I know you have a meeting.
Yeah, I have a meeting at 11, but it's fine. I just sent a text message to say
okay, Alex.
Not so late, I guess.
Okay, then I will begin the question with you because we likely don't have a question from our participants here, but according to the presentation of Professor Flau, I think he pointed out about the political decision makers, because with the examples of countries in Asia and some countries with BRICS countries, we can see that they did better. But why here in Europe or in West Europe we cannot move in this direction? And as you are the counselor of the government, I will have some answer about this question from you.
Yeah, as part of the French Scientific Council, I think we what we have been advocating for was to act early and strong, basically. And that happened on 2 occasions in September, when we were quite convinced that there would be a second wave happening somewhere in October, November. And again in January, when we felt like with the UK variant, we would have a third wave. What clearly, the context was a bit different. In September, we were just out of the summer, you know, and people were coming back relaxed. And it was extremely difficult in the first 2 weeks of September, also in the media, to talk about a possible second wave when you had some pseudoscientists who were saying that there would not be a second wave. And it's, well, I mean, it was their word against ours, and there was no way we could be, unless we would be very arrogant and say these guys know nothing. I mean, we could not really win the challenge. Also, they can be incredibly self-confident when they talk. And whereas we are, like Antoine, you know, full of our own contradictions and saying we cannot predict beyond 7 days or whatever. So when you have in front of you a guy who says, I'm absolutely sure there won't be a second wave, people feel like, well, there is this guy, he doesn't know what he, and this other one, and I like what he's saying, you know, it's exactly what I want to hear. So and what was really clear is that if we had to take at that time the right measures, it was exactly at a time where people were back from holidays, quite happy, and you had absolutely no sign in the hospitals or whatever of any tension. We could see that there was an exponential growth which had started early August, and it was going to happen with an increase of 30% per week. You could pretty easily see where we were going, but the hospitals were still relatively empty, and asking to close bars, restaurants, and reduce social life at a time where the situation looked pretty okay was extremely difficult for the public opinion, to also with those scientific controversies. And I can imagine that for a government, with all those hesitations, they felt like, let's wait and see a little bit. And unfortunately, things went as we feared it would. We had the same situation in January, because the story of this UK variant was based on what our colleagues from Great Britain were telling us with their models, and they said, well, there is a 50% increase. I remember very well, you know, when we had our discussion with the Imperial College on December 10, and it was 5 days after they had seen the curve going up, and they sent the first signal in saying something wrong is happening in the UK. By 22 of December, we were confident enough with the Scientific Council to make a statement and say there is a third wave coming up based on the data they gave. But here again, we were a little bit preaching in the desert. You know, it was Christmas time, and there had been this decision to keep this high level of people were comfortable with this very high level of hospitalization and everything. And again, I think there was the strength that you need to get those decisions made to control the epidemic when it doesn't look catastrophic for government it's a challenge. Myself, I would consider Germany and Denmark in Europe as the two countries which probably have been the more aggressive, you know, in their fight against the epidemic. Other countries did better, like Finland, Norway, but maybe the population density is so low that it's not a good comparison. But Denmark and Germany, for me, have done pretty well. And when Antoine was using the term of mitigation for Germany, I would put them a little bit closer to suppression than mitigation. I think they try better than anybody else, but I'm not sure. And they did it with a certain level of success, but it is clear that we were not either organized like China, which means real control on people, or with more favorable situations like Ireland, and Antoine mentioned it in his before last slide. It's true that for countries who have full control of their border, it's probably easier. Well, it's not. It's never easy, but it's conceivable to do it. Whereas for Europe, we would have needed a decision at the European level to go for it. I would say, had we not had a vaccine, I think we would be today in Europe going for a zero COVID strategy.
Yes.
Because that would have been the only way to make it livable. I'm not sure this is English, but livable or whatever.
Yeah.
But with the vaccine, I think then the perspective changed a little bit. But we would be completely extenuated, you know, without a vaccine now, with a series of lockdowns and rise and lockdowns and rise. And I think we would have all agreed finally at the European level that the only way out is probably a zero COVID strategy with all the constraints it brings. But with the vaccine, I think it became much more difficult to go for, to bring together all European countries on a strategy that is so demanding, you know. And well, anyway, I just hope we won't have to do this again. It will be without me, I can tell you. I mean, it's 15 months of that is enough for me. We will ask Antoine to come back to France and to work for.
Okay. Thank you very much. Actually, we don't have enough time, but now we are having some questions here. I think maybe some of you can answer this question from Sophie Joanno. She asked, what is not clear for me is the level of knowledge about pandemic management. Where is it? About pandemic management among government decision makers. Do you feel that when the pandemic started, they understood the respective implication of mitigation versus suppression? I don't know if Maybe Antoine, Antoine Flower?
Yes, thank you. In a very quick words, I'd say no, of course, nobody knew before, I think, I don't know what my colleagues think about that, but nobody knew exactly what will be the best strategy. In fact, mitigation strategy was a natural strategy. When you receive a wave in front of you, you have no time to think about that. What was the suppression or the elimination strategy was the first choice for small countries like Hong Kong, Taiwan, Singapore. Why? It's because also they were much more alerted and prepared and took lessons from the SARS episode than we were. And maybe because of that, they recognized it was not influenza and they wanted to suppress it as if it was SARS. So they thought, if it is SARS, we need to act as if it is SARS. And they acted for suppression, when most of the other countries just thought it was like a pandemic flu at worst, and they will act as a pandemic flu. That's my thinking. What is true is that nowadays we have a quasi-experiment in front of us with all these countries selecting different strategies. Some are rich, some are poor, some are authoritarian, some are democratic, so some are islands, some are not. And we will, it's a bit too early, but we will be able in a few months to assess. And what I agree also with Arnaud is that some countries, typically like Germany, has some in the middle, not really suppression, not really mitigation. So there are also some, I would say, in
a
between.
kind of mix.
Yeah.
Okay, thank you very much. The next question, I think, Professor Ralph Ranches, you can answer this. That is about what are the future perspectives for the use of backward tracing in Europe? It is a question from Florian Verrier.
Yeah, I think I would also refer this to Antoine.
Okay, Antoine.
Backward tracing, Arnaud may know that in French, in France, I think the Social Security has decided yesterday to implement from the 1st of July a backward tracing strategy for all cases. You know, with 1,000 cases per day, it will be much easier to do that. It was not possible with 10,000 cases or more per day. So now it becomes possible first to sequence all the genomes of all the new cases, because, for instance, in France, the capacity is between 1,000 to 2,000, correct me, I know if I'm wrong, per day in terms of sequencing. So it will become possible to sequence everyone, and it will be possible to backtrace every cases extensively, comprehensively.
Yeah, we have an ongoing study where we interview cases about circumstances of transmission, and we identified that for 15% of them, they were infected in a context that would suggest a possible cluster. So it's exactly what Antoine was saying. Now that we are down to numbers which can be grasped by the health authorities, and backward tracing has become possible, if when people say, well, I was at this event where we were 20 and that's where I got contaminated, and that would be 10 to 15% of the interviews we have now. We have more than 150,000 cases that have been interviewed, and this is what we are witnessing. So they will do it. It's the difficulty currently is that in France we don't have the culture of field teams. It's all happening by phone. There have been a lot of improvements, and the teams call back, and now they offer that you have someone visiting you and helping you at home, which between 10 and 20% of people accept if they feel like they cannot get isolated properly because of the home being too small or whatever. But the idea of really enforcing it by home visits, which I think psychologically also have an impact, is not something that has been performed in France and has been performed much more in Southeast Asia, and probably has contributed to the success of the tracing in Asia. It also requires that you have the staff to do it. And in France, we don't have anyone trained to do this. You know, it's at the time we were wondering how we could organize it. And we had an unfortunate word with the Scientific Council. I think we called about brigade mobile, which is a bit military. And we had put that in our back in April 2020, you know, that we should have this sort of brigade to go to the homes of people and to organize it. But unfortunately, when we started to look around and try to find who could do it, then it turned out to be complicated. And but now we are back in a situation where eventually we will have a chance to do it, which is particularly important with the Indian variant, because it's really it will become soon the dominant variant in France. When I say soon, it's a few weeks. I remember what Antoine just said. So,
yeah,
but
okay.
I doubt we would escape from it, basically, and we know it's really transmissible. So here we are.
Okay, thank you. And the next question, Professor Hoffman, are you there? Professor Hoffman?
I'm here. Don't you
Yeah.
see me?
Okay.
I see you.
There is a question here from one of our participants. She is asking, she thinks it will be very interesting to return to Mr. Fontane's question on the role that federalism played in Germany response to the virus. What do you think about that? Because from Fontane, it was just a question, and this participant want to have a point of view. And I think as epidemiologists from Mecklenburg-Vorpommern, one of the Bundesland with a few cases of incidence rate of COVID-19, maybe you have something to say about the role that the federalism plays during this COVID crisis. What do you think about it?
Yeah, maybe I start, because I've been quite close to our politics, which is not so hard in the small federal state that we are in. And we had a very determined leadership, in particularly our Prime Minister. She has recently suffered from cancer, so she was very aware of health risks of different kinds, and she was one of the most outspoken anti-COVID fighters in Germany. So even though the country is the federal state is quite small, she had a major voice in the discussion of the prime ministers, and she was very consistent in her politics. So that is commonly regarded as one of the reasons why we had small numbers throughout. Of course, there's other reasons too, but one of the main things that was very hurting to our economy was that we didn't let in the tourists. So usually we have some 3 million tourists with a population of 1.7 million over the summers, and there was basically locked. The country was locked for them, so which was very unpopular, obviously, in our country, but may in our federal state, but may have contributed very much. So I would say that if there was anything like a pandemic preparedness in a very, very minor form, but when it started, it paid off to be consistent and to be consequent, which not all of the other federal state leaders were. And of course there was a very diverse depth of knowledge. There were some who were really like the self-declared scientists, as Arnaud mentioned, and so which have really done much harm to the discussion. So until Angela Merkel had to say, now over with, we will now do it on a nation level, which is unusual for Germany. So, but I would just add one thing. I think we should have the idea or the concept of pandemic preparedness in our discussion. Maybe if there's a chance to talk about that, who would be in charge who would take responsibility to organize that in times with no pandemic, that we make sure that we better prepare next time.
Okay, thank you for this answer. Professor Ralph Ranches have to leave us now. So
I will also go, Aissa. It was
yes,
really
I
a
think
pleasure,
yes.
but I'm 25 minutes late, which in France is normal. But I think that Ralph is trying to be on time for his at 11:30. This is
Unfortunately, I have to be on time. Sorry. Thank you very much for this great meeting, and keep on discussing.
Yeah, keep up the good work.
Bye.
And stay strong, please.
Goodbye.
Thank you.
Okay. Thank you to all the participants, and thank you particularly to you, all the speakers. I am very, very happy to have this discussion with you today, and I really, really thank you very much for being here with us at Sciences Po. Thank you very much.